All right, Baltimore City Council Ways and Means Committee. We're back for Council Ordinance 24-0521, Ordinance of Estimates for the fiscal year ending June 30, 2025. I'm Mayor Costello, Councilman from the 11th District, Chair of the committee. Starting on my far right, Council Vice President Sharon Green Middleton, 6th District, member of the committee. Councilman Mark Conway, 4th District. Councilwoman Felicia Porter, 10th District. To my left, Councilwoman Danny McCray, Vice Chair of the committee, 2nd District, and Councilwoman Odette Ramos, 14th District. To my immediate right is Nia Garrett, staff to the committee. We're also joined by members of the Mayor's Office and the Council President's Office. We are here for Baltimore City Health Department, or Health. Commissioner, how much time do you anticipate needing for your presentation?
Good morning. Probably not more than 15 or 20 minutes.
15 to 20 minutes is perfect.
Okay.
So, Commissioner, I'm going to turn it over to you in a second. Have you do your presentation, then I'll go over ground rules with the committee for questions. I'm going to ask that before you begin, first and last name of everyone that's here to testify, specifically those folks sitting in the council seats, as well as their position title, and then you can take it away with the presentation, please and thank you.
Good morning, Chair Costello, Honorable City Council members, staff of Baltimore City Government, and members of the public. I want to thank you for giving the Health Department the opportunity today to speak about our proposed budget for the next fiscal year and the work that we're already doing. I also want to thank Mayor Scott and the city leadership for the support that they've provided for us through this process, as well as the Finance Department. The Health Department today is represented by myself. My name is Ihuama Emenuga, Baltimore City Commissioner of Health, and then our leadership team, and I'm going to go through the names and the positions as directed by the chair. Hyung Tan, who is the Deputy Commissioner for Aging and Community Services. Kedra Rowe, Director of the Office of Client Services. Alice Huang, Acting Assistant Commissioner for Community Services. James McGill, Assistant Commissioner, Advocacy Services. Byron Pugh, Assistant Commissioner, Home and Community-Based Services. Rachel Fender, Special Assistant to the Deputy Commissioner for Aging. Under the Division of Population Health and Disease Prevention, Deputy Commissioner Jennifer Martin. Brittany Spencer, Director of Opioid Overdose Prevention. Lanisha Childs, Assistant Commissioner, Communicable Disease and Outbreak Control. Dr. Adina Greenbaum, Assistant Commissioner, Clinical Services and HIV Prevention. Dr. Christine Oboe, Assistant Commissioner, Ryan White and Community Risk Reduction Services. For the Division of Youth Wellness and Community Health, we have the Deputy Commissioner, Mary Beth Haller. Rebecca Deneen, Assistant Commissioner, Maternal and Child Health. Francine Childs, Assistant Commissioner for School Health. Jessica Speaker, Assistant Commissioner, Environmental Health. Sharon Colburn, Director of Animal Control. Brian Gilks, Director of Health Promotion and Disease Prevention. Margaret Schitzer, Director, Community Asthma Program. Julie DiGirolamo, Director, Childhood Lead Poisoning Prevention Program. Aisha Burgess, Director of the Office of Youth and Trauma Services. Katrina Brooks, Assistant Director, Office of Youth and Trauma Services. For the Division of Finance and Administration, we have Kimberly Eshelman, Director of the Office of Public Health Preparedness and Response. Kelly Eastman, Chief of Staff and Chief Operating Officer. Unyime Epa, Chief Financial Officer. Liban Jama, Deputy Chief Financial Officer. Sadia McKeith, Chief Health Policy Officer. Julia Roche, Director of Legislative Affairs. Blair Adams, Communications Director. And then for our quasi-government agency partners, we have Adrian Bredenstein, who's the Vice President for Policy and Communications at BHSB. And we have Dan Rabbit, who's the Policy Director at BHSB. Oh, sorry, I did skip one person, and Shonda DeShields, who is in our Field Health Services Division. That's everyone who's here on behalf of the Health Department. The first slide you see just talks about how our service lines are organized, and it takes you through the overall health agenda, the clinical services, healthy homes, substance use disorders and mental health, maternal and child health. I won't read through all of them because we're going to go through them slide by slide anyway, but this does give you an overview of the services that we'll be talking about today. So the health department's mission is to protect health, eliminate disparities, and enhance the well-being of everyone in our community through education, coordination, advocacy, and direct service delivery. For the next fiscal year, we have two overarching goals. As you know, the health department does a whole lot of different things, but there are two things that are guiding the way we look at our services and the patients and the community that we serve. Our first goal is to improve equitable and inclusive access to healthcare services and evidence-based interventions which address the city's most pervasive public health challenges while strengthening our collaborative partnerships. And so from this goal, you can tell that collaboration is going to be very important for us in this next fiscal year, recognizing that we do have a lot of work to do, but also recognizing that we can't do it by ourselves. We want to be able to collaborate across partner agencies, across our community partners, but in a way that's equitable and does include everyone, excluding no one. Our second goal is to lay the foundation for resilient and robust public health infrastructure for the future through data-driven decision-making, enhanced operations, streamlined processes, strategic recruitment and retention, and increased staff access to training and development. And what we're saying in this goal is that we understand that money is important. Outside of dollars and cents, there isn't that much we can do. But we know that money doesn't walk and money doesn't talk. And so at the end of the day, we still have to be able to have the right staff in the right positions, doing the right job. So we want to make sure that we have people. But those people have to work within a structure. That structure is dictated by the processes that we develop. And our hope is that those processes will be developed in an evidence-based, data-driven way. And so these two overarching goals will oversee most of the work that we're doing over the course of this year, ensuring that we include everyone, we don't exclude people, but that we have a structure within which we do it, because like I love to say, we're trying to rebuild the public health infrastructure of the future, not just for today and definitely not for yesterday. So a lot of this will be future-driven, making sure that we're prepared for the next pandemic, not if it comes, but when it comes. And so I'll go through our services as briefly as I can, and then we'll open it up to questions. Our clinical services division does a lot with preventative healthcare. We are a public health institution, and so majority of what we do is preventative around treatment and some treatment of communicable and non-communicable diseases. Over this year, the next year, we're hoping to be able to fund a little better our ability to investigate outbreaks and disease investigation. And our targets, the proxies we're using as a metric for our progress this year is looking at the percentage of our TB infections that we're able to address, as well as the number of dental visits, and that's what you see on this slide. Under our Healthy Homes initiative, this is where, as most people know, we talk about lead poisoning, asthma home visits, and these are under the Healthy Homes pillar. We have a target of 500 homes that we intend to visit over the course of the next fiscal year. And our target is, you'll notice that our target has consistently been above 90%, is to continue to be able to ensure that by the third home visit, we have less visits to the emergency room. Under 307, our substance use disorder and mental health services. Some of the services that we provide here, we do in partnership with our sister agency, BHSB, one of our quasis. And here we're looking at calls to our crisis teams, as well as patients who are admitted to the Crisis Stabilization Center. You can see our target is slightly increased this year. We're hopeful that we will be able to meet that target. Under maternal and child health, this is mostly the children and health services. Everybody, I think, knows about Be More for Healthy Babies, which is probably one of our most successful programs. But this all comes under this program and talks about our home visiting services for mothers and for children. Our target this year is to have at least 90% of these children receiving services in order to target the needs that they have. And we're also counting the number of unduplicated families that we reached under this service. Our next service category is school health. I often say a service that's very near and dear to me. And with this service, we're also partnering with City Schools. City Schools has now taken over a proportion of our schools, which they are helping us to manage, and staff as well. And so what you see here is a reflection of the collaboration between the health department and City Schools. And you see the number of health visits. We continue to target over 250,000 visits a year with a return to class rate of over 80%. Our home and community-based services talks about the work that we do with our older adult citizens, and our target, our target for this year remains ambitious, and we expect to meet that, both in the service assessments as well as the nurse visits. Under emergency services, we do have here some cuts as a result of the end of the COVID funding that funded this program for outbreaks, but we still continue to expect to have some targets for investigating outbreaks as well as confirming the etiology of the outbreaks. Under youth and trauma services, we're targeting organizations and the staff that we train on trauma-informed care, as well as counting and taking a note of the victims that we serve, unduplicated victims. This next slide is just, I would say, this talks about mostly our administration. Included here, you may note, is it talks about our patient billing software. This is new to the health department and new to the city. It's the first time we're going to have an across-city electronic medical record that will help us to have a central database for our patients, the services we provide, and will really enhance our ability to have accurate data on who we're serving and how. Under animal services, we're fortunate this year to have some increase in our contribution to BARCs, and also a budget enhancement that is going to enable us to obtain new animal control vehicles. This is something that the health department has asked for a while, so we're very happy that we're going to be able to do that this year, while we continue to target the complaints that we close over time and the live release date of the animals where we intervene. Under environmental services, we continue to target a short enough time in responding to requests for inspection and applications, as well as visits to our food service facilities. Under chronic disease prevention, we're going to maintain the work that we're doing, monitoring our tobacco outlets, as well as our virtual supermarket services to the clients that we serve. Under HIV treatment, unfortunately, we are experiencing, or we will experience in the next year, significant cuts to that program. We're going through the process at the moment, having conversations with both the state as well as our community partners to ensure that our patients don't fall through the cracks and that we do find other ways to ensure that people are supported and served. This slide, 721, talks about our senior centers. As you know, the health department operates 7 senior centers, but we also support others. And our intention is to continue to provide assistance to these clients and to monitor the number of clients that we're serving. I do want to highlight the difference between FY2024 and 25. If anyone does have a question in their mind, it looks like a 56,000 patient cut down to 20,000. That's just a counting error. In the past, what was counted was the number of services. In other words, one person could be served 5, 6 times, and we count each of those. The preference is to count the number of people being served, so unduplicated patients. So what you see is just a reflection of that. It is not a drop in the target. I just wanted to make that clear. 722, this is a slide that actually shouldn't be here, but I think somehow it's been carried over from year to year. It's no longer in this category. This just covers a service that occurs under our aging category, so I'll simply skip over it. Under our advocacy for older adults, we are tracking the number of calls that we process for the Maryland Access Point to provide services and support to our older adults, as well as those that we support through counseling sessions for Medicare. Again, going to direct care and support planning. This also targets a lot of our older adults, and these are services that provide companions, volunteer companions to our senior older adults, as well as how we manage our guardianship cases. 725 is also support to our senior adults, and this talks about our home-delivered meals. This is a very popular program, and our older citizens really appreciate this. And we're counting how many home-delivered meals we administer, as well as the community-served meals. And I believe that brings me to the end of our presentation. I hope I didn't go too fast, and we're happy to answer any questions that members may have. Thank you.
Thank you. We've also been joined by Councilman Z. Cohen, 1st District. Bob, is the, can you provide me some guidance? Is the appropriation for barks included within the Health Department?
It's under Animal Services.
Under Animal Services. I'll come back to that. Council Vice President Middleton.
Thank you, Mr. Chair, and thank you for your presentation and for you and your team and the work you can continue to do throughout the city. Mr. Chair, is it one question?
Thank you for the reminder, Madam Vice President. I didn't go over ground rules. We're going to do one question per person. We're going to use the same format that we used last evening for the police department. For those that weren't present, 1 minute for the question. If you go beyond the minute, I'm going to ask our colleagues if anyone has concerns with extending your time 30 seconds, and each member will be afforded one follow-up question of up to 30 seconds as long as it's directly germane. We'll move through this hearing very efficiently and effectively and make sure each council member gets all of their questions answered. So if you could take it away, Madam Vice President.
Thank you, Mr. Chair, and most of my questions are probably focused on partnerships. I know on the page you had mentioned, I'll start with the number 308, maternal and child health. And your Be More Healthy Babies program is a wonderful, successful program. And just kind of wondering if you have partnerships with other, I guess, similar nonprofit programs throughout the city. I know that Park Heights Renaissance has a strong hippie program that's helped with the help of the Family League. And do you have a partnership also with the Family League? Are you partnered with hippie, or are you interested, or please comment.
Thank you, Vice President. That's an excellent question. And like you said, the Be More for Healthy Babies is well known, and it does constitute a lot of partnership. It's actually probably one of our strongest steering committees among the programs we have. And the committee members are very invested, always looking for opportunities for us to receive more funding and to work with other people. I can invite our Deputy Commissioner to speak more if you'd like details about all the programs or different partners doing similar things that we are doing in the program. What I can tell you off the top of my head is that we are having conversations with a number of philanthropic organizations that are interested in helping to fund it, just because the model has been so successful, and there's a lot of interest in replicating that model, not just across the city, but actually across the state. We feel very validated by that, by the interest, and we want to make sure that we do it the right way, in a way that's sustainable as well. As you know, the program works really hard to sustain the funding, but if you'd like details on who exactly we may be partnering with, I can invite one of our deputy commissioners to speak to that. Would you like that, ma'am?
Yes, and I guess request for the chair to, if you have a list of those partnerships that you could share with us.
We can also do that. If you'd like us to do that offline, we can. Okay. We can, after the hearing, follow up with you with a more detailed list of other programs. Yes, sir.
If you could summarize that request, Madam Vice President.
If they could give us an updated list of their partners with the Be More Healthy program. And I ask for that so we can, help you add to maybe some new programs that are out there that would like to partner. I know that the Family League is very much interested in helping to continue with that as well. But if we could have just that's all we need, I think, is a list of the programs and where they are with the partnerships.
Okay, so Assistant Commissioner Deneen is right here. She can add some details.
Yep.
Go ahead, sir.
Hang on 1 second. Richard, list of partners for the Be More Healthy. Excellent. Please continue.
So I'm going to allow Assistant Commissioner Deneen to speak to the Family League situation, and then we can follow up with more details for you later.
Sure. Good morning.
Hello? Okay, there you go. Good morning and thank you. I'm Assistant Commissioner for Maternal and Child Health. My name is Rebecca Deneen. It's so good to be here. Yes, Family League, I just wanted to add, the Family League is our lead implementing partner under Be More for Healthy Babies, along with Healthcare Access Maryland. And so very much we partner every day. In fact, we were just together yesterday. We are very familiar with the HIPPY program, but would love to, we will list out the partners, and it's also available on our website, healthybabiesbaltimore.com.
Thank you. And just to add, I think one of the interests, and I know for the council, especially Councilman Cohen, our interests with the school system in trying to make universal pre-health care and all that, we just want to make sure a lot of those connections are really, and partnerships are really happening as well. Thank you, Mr. Chair.
Thank you. We've also been joined by Councilman Ryan Dorsey, 3rd District member of the committee, Vice Chair McCray.
Thank you, Mr. Chair. Commissioner, I wanted to just double back and get some updates on some goals that were set for FY24, specifically regarding the expansion of the Healthcare on the Spot mobile and also the buprenorphine program as well. Can you provide an update on that goal that was set in just FY24?
Did you want me to speak generally to answer that, or is there a page you'd like to refer me to?
So it's regarding all of your goals that were set for FY24. I can give them to you. I have a document
I have
of
a
them.
copy.
But the first one was simply, one of the agency goals in FY24 was the expansion of the Healthcare on the Spot mobile, as well as the buprenorphine program as well.
Okay, so thank you for that. Deputy Commissioner Martin will speak to the spot van, which is what you're referring to, and the buprenorphine program.
Good morning, Jennifer Martin, Deputy Commissioner for Population Health and Disease Prevention. Thank you for your question, Councilwoman McCray. We have been working to expand the work of the Healthcare on the Spot. We have unfortunately encountered a lot of funding challenges. Many of the funding sources that have been supporting that work are coming to an end. We have been seeking out additional new grant funding sources. We did apply for several grants in FY24 that would help to support the work of the spot, both through the health department as well as through Johns Hopkins University, which is our private sector partner on the healthcare on the spot. Unfortunately, we have not been have not received any new funding. One of our grant applications was awarded but not funded due to a lack of funding at the CDC. So in our FY25 budget proposal, we have asked, and the city is giving us some additional funding to help cover some of the budget shortfalls as we're looking ahead into FY25. We do still want to work to expand the work of the SPOT program. That is still a priority of the health department, and we continue to seek out additional funding to do so.
What measures do you use to measure the success of healthcare on the spot?
Thank you for that question. As a clinical program, we have a number of clinical outcome measures that we monitor and conduct quality assurance on a regular basis. The healthcare on the spot, in addition to providing low barrier buprenorphine access to individuals, also provides a number of other services, including HIV and hepatitis C testing and linkage to treatment, wound care. They do naloxone training and distribution. They recently began providing syringe exchange services on the healthcare on the spot as well. So there are a number of measures that we look at in that program, including retention in the program, looking at continued medication adherence, as well as looking at their connection to other services and their continued care.
Thank you. Just as one last follow-up, I'm going to be quick. Right now, it looks like the schedule on the website is up until May. Is there a lapse right now, or will we be putting the schedule for the on-the-spot mobile on the website so we could see?
Yeah.
It was great for me to reference and give to constituents to say, hey, here's the schedule, this is where it's going to be, but I'm just not showing anything from June or for the coming months.
Yeah, thank you for that. We have provided the updated schedule to our comms team, and it is being posted on the website. I'm not sure if it is up to date or not, but I can check on that after our hearing today. But yes, we are working to make sure that the information on our website is up to date and accurate. We do have some planned changes this summer in locations. So we continue to evaluate the locations where we provide those services. We will be making some changes over the summer so that we can shift to be able to provide service in the areas of greatest need. And we are working to shift patients to other locations or connect them to other providers. Some of our locations are quite close together, so folks can come to the nearby location to continue to receive services, or we will be also offering to connect them to another provider to continue care.
Okay, thank you. I'm going to hold my questions because we only have one.
Thank you. I'm mostly just here to say thank you for all the work that you do. I think it's great. I'm really thrilled to have the Harford Senior Center in my district and to have such great support for the folks in Northeast Baltimore. It's the farthest northeast senior center in the city, so it serves a huge portion of the city's geography. And so I'm just really thankful to have it there and to have the renovations happening there. Young, thank you so much for your work. I just wanted the program that's most used there is the Eating Together program. It's one of the most popular programs. Is there any, are we at capacity for this program, or is there more that we could do? It's such a popular program. I want to make sure that as many people as possible have access to it. Do we feed, do we have as many participants, and do we have the funding to have more participants if we have greater capacity?
Thank you, Councilman. If I heard you correctly, you're talking about the Eating Together program? All right, I'm going to allow Hyung to speak to that.
Hello, good morning. Hyung Tan, Deputy Commissioner of Aging and Community Support. Councilman Dorsey, thank you for your question and thank you for your consistent support of the Harford Road Senior Center. The Eating Together program is expanding, and it is one of our more popular programs aimed to help really drive some socialization among older adults. The Eating Together program is not at capacity at the Harford Road Senior Center. There is some outreach efforts to increase the number. We have a number of special events that occur through our, that we have a number of special events that occur throughout the year to recruit more members to the Eating Together program. Is there anything specific that you would like to know about the Eating Together program? I'd love to have Alice Wong, our Assistant Commissioner of Community Services, who spearheads that program, if there are any specific program questions.
I just really want to know if we have room for more people, if we have a plan or how we can be how we can assist in getting more people in if we have room for more people, and if we don't have funding for more people, what we would need to get, to fund our capacity better.
Absolutely. I believe at our current level of funding, it's both being supported through federal grants under the Older Americans Act as well as ARPA-funded support. We have 30 sites throughout the city currently, consistently looking at where the need is around the Eating Together program, but there is more capacity to expand and recruit new members to the Eating Together program.
What is the age? Is there a minimum age for participation?
Because it's funded through the Older Americans Act, the age eligibility is 60.
Okay, thank you.
Thank you. Councilman Conway.
Thank you, Mr. Chair. We've been talking a lot about recent news regarding opioid deaths across the city and really working across the various agencies to understand their role. Of course, the health department is probably the lead coordinator in a lot of these efforts. And I was really curious, kind of combing through the budget, I noted that we had a reduction in Service 307, substance abuse and mental health, largely due to reduction in federal grants. I'm curious how this affects services and operations and what we're thinking about doing to address that.
So before the health commissioner begins, so this is related to what Director Larson has talked about throughout this budget process. We just changed how we budgeted for grants. So we only budgeted for grants that we confirmed were already coming in. And so as additional federal dollars come in, they will come through as a supplemental appropriation. But the director can talk more about this.
Thank you, Councilman, for the question, and thank you, Madam CA, for jumping in. She said exactly what I was going to say. So it isn't real dollars and cents we lost. It's an accounting procedure. So it isn't less money to the program, and it definitely isn't less attention. As you know, it wouldn't make sense for anyone to give less attention to what we know right now is front and center.
I appreciate that explanation. It's super helpful. So as far as what we might reasonably expect, are we expecting a current level of service or any increase to this service?
And by service, I'm sure you mean not just dollars and cents, but the resources and programs going into it.
Precisely, yeah.
Yes. So yes, we all do expect an increase in the level of service and resources. We recognize that the overdose problem is beyond the health department. Mm-hmm. And as you rightly said, the health department may coordinate what goes on, but we recognize that there are multiple agencies that have an impact on the overdose epidemic, as well as whose work is impacted by it. And as everyone knows, the mayor has recently started an overdose cabinet of agency leaders who will be contributing to this effort. The governor has signed by executive order the overdose prevention team that is coordinated by the health department. There will be a lot of attention to this. Literally just 2 days ago, I met with the director of the CDC's National Program for Unintentional Injury, but it's put that way because it is under unintentional injury that the CDC intervenes with overdoses. So we have a lot of attention on it at the moment. We also have the right partners. We've received the silver lining of the article, as uncomfortable as it was that it did give a lot of attention to the challenges we're facing in the city. And as a result of that, we have had people reach out to us directly, offering help and support in order to make sure that we address this the right way. So in summary, we will see more resources, we will see more attention, and we will see the needle shift on this.
Mr. Chair, if it's okay, do we have any, because I appreciate we're expecting more resources, do we have any sense of how much more, anything that'll help me estimate how much more we're leaning into this issue given the urgency.
Can you ask that question one more time?
Are we able to estimate how much more or what additionally we're adding to these efforts given the urgency?
So given that a lot of these collaborative efforts are in the early stages, I can't give you exact numbers or figures. In a short time, we will be able to, and we would actually love to be able to provide you with those numbers because we want the efforts, we want to be held accountable for the effort that we're making.
Sure.
So we don't have those numbers right now, but we are moving in the right direction.
Is there a time that we might expect to know that information? A month, 2 months?
So our entire team is right here. These are people who are working their tails off to make this work happen. I can tell you, probably by the fall, we would have wrapped our head around the magnitude of what needs to be done and the direction in which we'll go. And we are very happy to reach out to you at that time and provide you with some more solid information.
Yeah, that would be helpful if we had a maybe a quarterly update at least on where we are with resources to understand how much more we're able to put toward this effort, and just give the council a better sense of what we can't necessarily put in the budget given the way we're accounting going forward. Thank you, Mr. Chair.
Thank you.
Thank you, Councilman Cohen.
Thank you, Mr. Chair. Thank you, Commissioner. I want to just start by thanking your predecessor, former Commissioner Gerasa, who did an outstanding job leading the city through the pandemic. I also want to thank Interim Commissioner Mary Beth Holler, who took over afterward and I think ably led us as well. And I'm really excited for your leadership, Commissioner. I also want to thank Katrina Brooks and the Youth and Trauma Services team. I think they do a phenomenal job. I'm so proud that Baltimore is leading the country in this work. We just received the Robert Wood Johnson Culture of Health Prize for our work around trauma. We have a mayor who truly believes that part of how we solve violence is through a public health approach, and that is exciting to be part of. We also have a governor in Annapolis who believes in this approach to the work. Could you talk about how you plan on addressing trauma and violence through your office with the funds that you are allocated?
Councilman Cohen, thank you very much for the question. And as you know, the health department is now working with the mayor's office with Monzi to address both youth and trauma. What I can do is invite, do you want to speak? Yes, I'm going to invite Mary Beth to speak in a little more detail into what that partnership looks like and some of the more details that you want around youth and trauma. You want to go ahead?
Good morning. Thank you for the question. Our office is involved in many aspects of the joint youth violence prevention project throughout Baltimore City. We work with all of the other agencies, our sister agencies like police, Monzi, of course, Mayor's Office of Children and Family Success. We are part of the Violence Prevention Task Force. We are also instrumental in working on the Mayor's Violence Prevention Framework. Under that framework, under the pillar that is one of the pillars assigned to health, we're looking to expand trauma-informed care beyond city agencies to community-based organizations, especially smaller community-based organizations that could really benefit from that training in the community, and potentially through train-the-trainer models even get more, more coverage for that kind of training, which is so valuable for everyone to understand. Those are just a couple of the things that we're working on. We are continuing our work around serving victims of crime and the trauma that they've experienced. Youth in particular, we work with them. We have peer ambassadors who go out into the community, work with youth, try and bring them in, teach them coping skills, leadership skills, really to help set them on a path and potentially even leading to employment, and provide mental health referral services, or even try and get them used to the idea of accepting mental health services, because there's still a lot of stigma around mental health services. those are just some of the things that we're working on.
Thank you for that, Deputy Commissioner, and thank you, Commissioner. Look, I think across the United States of America, cities, municipalities, rural, urban, whatever, are struggling with the mental health crisis. We see it particularly profoundly post-pandemic. We saw a rise in opioid overdoses all over the country. And I think this is an area, particularly around mental health and trauma, where Baltimore really is a national leader. And I'm hoping that your office will really lean into that, as Mary Beth and the great folks already have, and really do some work this year in capturing our data so that we can continue to show innovative and different approaches to solving this crisis and serve as a model for other cities. Because again, we know where we have significant challenges, but I also think it's important for us as a city to claim the things that we are doing well and that we are leading on and are innovative on. And it is my hope that you as our new commissioner will really lean into this work, and particularly around data capture and understanding what it looks like on the ground.
Thank you, Councilman. I appreciate that.
Thank you.
Thank you. Councilwoman Porter.
Thank you, Mr. Chair. Commissioner, first of all, welcome. It's good to see you in the city again. I wanted to first kind of go through service number 303, clinical services. I wanted to know, since non-communicable diseases such as diabetes, cardiovascular disease, they're really big as far as preventative care for many Americans. How are you all addressing those chronic diseases? I see that tuberculosis is the only one mentioned, but I just want to really understand how you all are addressing that, and what services and what resources you all are putting forth to those kind of major diseases that we're seeing in Baltimore City in particular.
Thank you, Councilwoman, and it's good to see you too again. So with public health, a lot of our work is preventative. But again, as a public health agency, when it comes to chronic disease, a lot of what we do is really partnering. I don't know if you've heard the term LHIC that we talk about, which is our Local Health Improvement Coalition. And this is with working with partners who are actually the primary providers of clinical services. So we're not a provider primarily of primary care. We couldn't be. We are the provider of last resort for many preventative services. You see tuberculosis here because this is a population-based concern. If you'd like specific details of what we may do in these areas, I can defer to our deputy commissioner, but I will tell you that we do this work mostly through our partners who are the frontline clinical service providers. We want to be there to provide technical assistance. We want to be there as a convener. We want to be there to help with policy that guides the work that they do. And that's what we do mostly.
That's wonderful, and I'm so glad you mentioned the policy perspective. So let me clarify my question. This was more about what partnerships you all are using. So for example, in the state of Michigan, they have they've expanded and kind of went a little bit above and beyond for their COVID-19 mobile clinics that they had out in the community, and they've transitioned them to kind of preventative, even car or bicycle focused mobile health screening. So they are using that infrastructure of COVID-19 to screen for diabetes, to screen for tobacco, to screen for some of those non-communicable diseases that they have, within their state. I'm wondering how we can utilize that infrastructure here, given that we have the infrastructure. We were very successful with University of Maryland, Dr. Chuck Callahan, and the COVID-19 infrastructure. How can we transition that infrastructure into some of the mobile infrastructure that we need to see in the community? Because we are seeing a reduction in access to healthcare, people going to the hospitals and their primary care providers. So we need to think a little bit more non-traditional about how we kind of make that bridge for those preventative healthcare screenings.
So I'm so glad you asked that question. And I almost brought this topic up when Councilwoman McCray talked about the spot van.
Yep.
Almost everyone looks at the spot van as just BUP services and harm reduction. But mobile health is special because people often refer to it as a service that serves the can'ts and the won'ts, those who cannot come to brick and mortar clinical care, and also those who just won't. And somehow we have to reach them. And what you're referring to in the city of Detroit is a program where they have actually got third-party payers to recognize this as a medical home for certain people. We would love to go in that direction. The health department is involved in the conversations. These are very early conversations in Baltimore City right now. About, I want to say it was 3 months ago, we had the first convening of everyone in the city who is working in mobile health. And I was actually blown away by the number of people that were in the room and the little pockets of people that had these mobile vans. At this point, I think every single FQHC in the city owns at least one mobile van, and I believe one of them is in the process of getting the second one, as you know. And so we want to be able to leverage that service to reach people who may have come in for BUP, but at the same time, you know, people often say, patients don't read the textbook. It's not like when you have diabetes, you can't have chronic heart disease, or when you have substance use disorder, you can't have hypertension. People come with different things, and so it's our responsibility to recognize that and use that. So we're hoping that going forward, mobile health will be a thing for the city of Baltimore. We will be able to lead the state in that effort, starting with the one little spot van that we have and moving that into larger services. And that would probably be our best way of supporting that chronic disease program. So thank you for asking this.
Sure, and so Dr. Callahan and Dr. Davis and I have been working kind of to map out the mobile health clinics throughout the city and kind of what their services are. One of the major issues is they don't have a reimbursable code at the state level. And so CA, I'm wondering if that can be an aspect of the legislative agenda for the Baltimore City Health Department in the upcoming General Assembly, because that is going to allow us to begin to build that infrastructure, that reimbursable infrastructure from CMS, from Medicaid, Medicare, for the mobile health clinics throughout the city. Thank you.
Thank you.
Councilwoman Ramos.
Thank you, Mr. Chair. Staying a little bit with the clinical services, there was an article in the paper the other day, and I have been talking with some constituents that several clinicians in the health department are being laid off because of funding relative to Ryan White funding and sexual health funding, and that the two clinics on each side of the city are going to be doing limited hours as a result. And we actually, I did not know this, I'm not a clinician, that we actually have a pretty significant rise in one of the types of syphilis happening in the city. And so if the services are going down, but the numbers are going up, that is an issue. Can we talk a little bit about what's happening at the sexual health clinics and that funding? I know that there's a partnership with, I'm just trying to put it all together. There's a partnership with Johns Hopkins, there's a partnership with the state, there was an issue with some state money. If somebody can explain that and then help us to help you be able to provide those very important services.
Colleagues, do we have a
I was done. Go ahead.
Thank you, Councilwoman, for that question. And I spoke briefly about that when I spoke on the slide on clinical services. So what you're referring to about the funding is there's a proportion of our clinical services, specifically around Ryan White and the HIV services, which is tied together with STIs, that we receive from the state. And the state cut that funding, ran out of funds for that money, and our funding was cut by 75%. That's a large proportion of funding to lose for any stream of programs. And when I spoke about it briefly, I talked about the fact that we're continuing to have conversations with the state as well as our community partners. Our aim is to ensure that our patients don't fall through the cracks. We partner with a number of FQHCs, and the partners you're referring to, some of the academic institutions like Hopkins, the FQHCs, they also see the same patients. We also support them to do that. And we're encouraging them to also look at other funding streams. And so even though there are parts of the funding that we will not be able to fund, and if you have more questions, I will also refer to Deputy Commissioner Martin to add more. But even though there are parts of the service we won't be able to fund, we're working very hard to ensure that patients don't fall through the cracks, that the program isn't just shut down. I mean, as you can imagine, 75% is a lot to lose, and the partners are very sad by this, as they should be. But we're working really closely with these partners. Just yesterday, actually, we had meetings with the state, and we're continuing to talk with them about how we pick up the services.
Thank you. I understood what you said earlier. I just wanted to focus on just the sexual health piece, and so that's the basis of my question. But also, is there going to be any advocacy to the state? My understanding is that this isn't like Ryan White funding federally is still there, but it was a mistake or something? I don't know. Are we looking at like we knew this funding was going down and then we had to prepare for it, but we didn't expect a 75%? I'm just trying to figure out how we can be helpful in terms of the advocacy side at the state level.
There's been a lot of advocacy from the academic institutions, from the FQHC environment. We didn't know the funding had run out until we were told some months ago. The state monitors those funds. We can't speak to when they knew it was going to run out, but they did inform us some months ago, and once they informed us, we had to inform our partners. I'm going to let Deputy Commissioner Martin speak to the question you asked about the clinics and the change in schedule in order to adapt to the change in funding. Is that okay? Yes, ma'am.
Thank you, Dr. Emanuga, and I'd like to invite Dr. Greenbaum to come up as well. When we're talking about the sexual health and wellness clinics at BCHD, we are having several changes in our funding, not just the HIV funding that Dr. Emanuga has been speaking to, but we also have some other exciting changes happening in our clinics with the rollout of our new EMR. And so we are changing our workflows in our clinics so that our clinicians will actually be able to see more patients, right? So each clinician will actually be able to see more patients than they currently do now under our old EMR. So while there are changes to
sorry,
this,
what's an EMR?
the electronic medical record. Yeah. So while it's true that yes, we have had to reduce the number of clinicians who will be working in our clinics in FY2025, all of our clinicians will be able to see more patients than they are currently. So our capacity, we don't believe at this time is going to be negatively impacted in terms of how many people that we are able to serve in the clinics, but of course that's something we'll need to monitor very carefully as we launch our new electronic medical record next week. It's very exciting. And we are implementing these changes in our clinic. We also are going to be instituting more widespread billing in our clinics at the health department with this transition to the new EMR, and we'll be also monitoring the revenue that billing generates and how that may impact the funding streams and the infrastructure, and whether we can change our clinician model moving forward. And Dr. Greenbaum, I don't know if there's anything you'd like to add.
Hi, I'm the Assistant Commissioner for Clinical Services and HIV/STI Prevention. My name is Dr. Adina Greenbaum. I think that was a pretty thorough explanation.
Ma'am, say your name just a little bit more slowly.
Sorry. Adina Greenbaum.
Thank you.
Yes. It is a very challenging funding atmosphere, especially when you are looking at clinical services and clinical services for sexual health. It's hard to get funding. It's increasingly hard to get funding for services that are considered billable in the medical system. That being said, we're doing the best we can to mitigate the impact of these funding cuts to the general public to ensure that their access to care is not further limited. So although we will need to transition transition our hours from what they are right now. We're looking at maximizing the hours that we are at our various locations. We've had some improvements in technology since we had a similar schedule back in 2016, 2017, where we did not have both of our sites open full-time for all services then. We're looking at improving on how we did it then. And there's some improvements in technology now where we hope to improve access and accessibility for patients. And we're looking very closely at our numbers of number of people seen, number of appointments available, and how we can improve the efficiency of our workflows and our systems to maximize the number of patients seen in the hours that we're open. And we're going to be following that capacity very closely. It is an unfortunate it's always an unfortunate timing when you have a decrease in funding, and to have a decrease in funding at the same time that you're seeing an increase in this case, you're correct that we are seeing an increase in syphilis. There's an increase in syphilis and other sexually transmitted infections nationwide, and we're seeing the same thing in Maryland and the same thing in Baltimore. There's a lot of things that we look at in order to address that. The clinical services that the health department provides is one piece of that. It's a very important piece because, as Dr. Emanuga said, we want to make sure that individuals who cannot get tested or their challenges getting tested or treated at the other medical providers across the city, that we are a place for them to be seen. The other things that we pay attention to when we're seeing these increases in diseases such as syphilis are the other activities that the health department does as a public health agency. Those include outreach, education, awareness among the general public, awareness among providers, that it's not just the health department doing the testing and doing the talking to people about this. As a community, we need to be doing this with our clinical providers and our community-based organizations. We have our outreach vans that do testing throughout the community to try to reach other places where not just in our clinics, those services are continuing and are not being impacted by this specific cut. We have partner services who are our contact tracers for HIV and syphilis, who make sure that we reach out and we work hard to reach every person who's newly infected with HIV or syphilis in the city to make sure they're in treatment somewhere, whether it be the health department or a different clinical provider in the city, and they understand their diagnosis and see if there's anything else they need in order to be treated. And then to reach out to their partners confidentially to say, you may have been exposed, we need to get tested. Can we link you to testing? Again, is that at the health department or at somewhere else? And using the data that we have to hone that response. So the clinical services that we provide are a critical piece of that, fitting into that larger picture.
Thanks for explaining that whole piece. Obviously there's a public health response to, increases.
Any follow-up directly to that?
I did have one quick.
Laser quick, correct?
Yep. So the 75% cut, it affects the services and treatment, not necessarily the testing and outreach? Or you have different funding for that, the testing and outreach piece?
It primarily affects clinical services. That's not, there is some impact on some of the other public health things we do, the outreach, the testing, but the most significant impact is on the clinical piece.
Thank you. Thank you so much. Thank you, Mr. Chair.
Thank you. Commissioner, who does Service 716, Animal Services? Which deputy commissioner does that fall, or who's the highest ranking person here on that? Ms. Haller.
Yeah.
Great to see you.
That would be Deputy Commissioner Haller.
Deputy Commissioner, on page 219 of Volume 1, Service 716, number of dogs and cats entering the shelter performance measure. In fiscal 22, we had an actual of, I'm rounding, 7,300. In 23, we had 10,400. Do we have any sense of what the actual is for fiscal 24?
I would have to get the number for 24. I don't believe we have that yet. But we do know why.
We do know.
Why the numbers are increasing.
Please.
And the numbers are increasing primarily because of the pandemic. All of the trauma, economic impact, everything felt by families and loss was also compounded by the inability for people to take care of their pets any longer, or to adopt if they had planned on adopting a pet. So there were many, many more pets being either abandoned or turned in at the shelter. And we haven't really recovered from that. Barks has been amazing and always has been at outreach and trying to keep pets in people's homes, providing food when they can, helping them, bridge those gaps so they do not have to surrender a pet that is really a family member. But that's why the numbers are going up. You may have seen in the news recently, just last week, the animal control officers, along with the sheriff's department, seized I think 83 dogs and 1 cat from a property. The shelter was already full. So this is an example of why this is increasing. Some people see, the breeding of animals like that as, an economic process.
Thank you. And I would imagine that you anticipate the actual for fiscal '24 without having the number in front of you to be higher than 10,400.
That's actually hard to say.
Okay.
It's hard to say.
And
we don't expect it to a big dip.
Okay, I'm gonna move on in a second. Try and follow my own rules here, back to my colleagues, but on page 220, we're in 219, the total appropriation, Bob, went from 3.7 to 4.6 million. What's that increase, and what does that increase accomplish?
So if you go, if you look on page 220, you can see the change table. Some of that is just the normal inflationary, cost of living, COLAs, adjustments, benefits. You can see there was 255,000 was for a new enforcement vehicle, repairs for enforcement vehicle, which is separate from Barks. So that's a big chunk of it. And then at the bottom, you can see we break out the activities. Animal enforcement is the health department folks that do the enforcement, and then animal care and rescue is what goes to Barks. So you can see the differences there, but the bulk of it is that new.
You're on 220, Bob?
Page 220.
Oh, increase in, an increase in contribution. And the Object 3 contractual services, there's an increase of about $232,000. What's that for?
That, I believe, is the funding for that vehicle.
Oh, okay.
Yeah.
Oh, so contractual services baseline went down slightly, and then the 250K bump for a net increase.
Yeah, and you can see in the table above, we show every difference between last year's adopted budget and this year's adopted or proposed budget, and the big changes. And you can see the top two is just the salary and benefits, and then lower down, the second from the bottom is that 255,000 for the vehicle.
So what's the total contribution to Barks here?
The total for Barks, if you look at the bottom of that page, you see the
Animal care and rescue.
Animal care and rescue, yeah. So there's a $1.5 million general fund contribution, and then there's also 120,000 that's budgeted from the casino because they're planned for 25, for fiscal 25, the South Baltimore Casino District. There's 120,000 in their plan this year for Barks.
When you say casino, are you talking about the South Baltimore Gateway Partnership Management Authority, or are you talking about the other half of the casino impact aid, which is the LDC funding?
I believe it's the other half of it.
The LDC funding?
I believe so, yes.
Which is at the discretion of the administration, correct?
Yes, with the input from the community.
Right.
Right, and I actually have, I would look this up, I have in front of me, there's a document on planning's website, the casino local impact funds, the FY25 draft, which lists 120,000 for Barks.
That is, which would be a typical budgeting practice. This isn't intended to be critical. That has not yet been approved by the LDC for formal recommendation to the mayor, but it is assumed in the budget.
I'm not sure if it's been approved yet. I'd have to check with planning of where that is in the process. But yeah, it's anticipating that if this plan were approved,
Got
that
it.
money would be
I'm gonna
available.
come back to the Barks funding. Last thing on this, do we have anyone from Barks here? No? Okay. Council Vice President Middleton.
Thank you, Mr. Chair. Mr. Chair, can I just do a follow-up request from the Eating Together program and then ask my question?
You sure can, Madam Vice President.
Thank you. Very important program. So I know that during COVID, it was kind of stopped for obvious reasons, and it picked back up. So if we could just have a list of the where the updated Eating Together programs are with the partnerships, because I know that that's a big part of the success of that program is having the partnerships, whether it's a church, fraternity, sorority, or wherever the locations that the partnerships are there. And if we could have that list, we could help with, you know, just advertising and getting more partnerships for that program.
Yes, ma'am.
I think it's a wonderful program to just really help eradicate hunger, especially with our older adult population. So my question basically is about Naxalon. And is there a partnership with the fire department? Or do you have just your own separate program different from theirs?
So the short answer is yes, there is a partnership. The overdose response is, we want it to be more coordinated, but it always has been coordinated with, and I'll let Deputy Commissioner Martin speak more to that, because we do work closely with the fire department. Please go ahead, Deputy Commissioner.
Thank you, Dr. Amanuga, and thank you, Vice President Middleton. We do partner and work very closely with the fire department around overdose. When it comes to naloxone, we have a good working relationship with them. The fire department is actually their own what's called a registered overdose response program with the state of Maryland, which means that they are able to access free naloxone directly from the state of Maryland. Something that we helped work with them to become. You know, we've been working with them for several years around naloxone distribution as part of their Leave Behind program, where they leave behind naloxone when they encounter non-fatal overdoses.
Thank you. Is that how you pronounce that? Naloxone? It's been
Naloxone.
It's been said so many different ways. And so, just lost my train of thought. Oh, and this is a follow-up to this. I think Dr. Nguyen was the commissioner when that drug was introduced, and there was a training for council members, and after that training, each council member received that drug to keep in their car to, you know, because we travel our districts, and I did happen to have had to use mine in a location, and from that training and all, you know, so is that a possibility for that to happen again?
So, Council Vice President Middleton, I believe what you're asking is, can we engage on another training exercise for council members?
Yes, and give us a, you know, one dose supply to keep with us in our travels.
Yes, we would love to do that.
All right, thank you.
Thank you, Mr. Chair. Just as a follow-up to that, one of the things we discussed in the Public Safety Committee was also maybe looking at keeping it in every government building across the city. That can go a long way towards knowing that there's at least access somewhere to naloxone.
Thank you, Councilman Conway. I want to thank you very much for that. That is something that we have been discussing for some time in the health department and with other city agencies. We would love to see naloxone offered in all city buildings. So thank you.
Vice Chair McCray.
Mr. Chair, I have a quick follow-up, then I'm going to ask my question. Just to follow up on that, can you all speak to the training that you've already been doing for city employees regarding the naloxone? In partnership with other agencies, specifically one I can think off the top, MONSE. Can you speak to the training that's already been done or that's ongoing?
Thank you, Councilwoman. Yes, I will let Deputy Commissioner Martin speak to the numbers and where we've done the training and what the trend is showing.
Yeah. Thank you, Dr. Emanuga, and thank you, Councilwoman McCray. I don't have the numbers with me today, but more than happy to provide them to you. But we have been working with several agencies, and as you mentioned, we have had a relationship with MONSE, where we did a train the trainer with them, and then they have done several trainings, I think specifically with offices here at City Hall, but also with some other city agencies. Last year, we also worked with DHR to develop a workday training that is available for all city employees. It is not a very long training, and it is an online training that is available to city employees. And once they complete that, there is a way for them to get naloxone directly from the health department once it's completed.
Just as a committee request, would you all be able to provide the amount of employees, Baltimore City employees, that you have trained within the last year? And I say that because I think it's important that we uplift, that we are actively training city employees with naloxone training. I was trained at an overdose prevention event. To get to my question, this is regarding opioid restitution funding planning. Can you all provide details on capacity building efforts that you've undertaken within the health department or that you will be forecasting for opioid restitution funding?
Thank you. So I'll start here to address this question, and then the health commissioner can follow up. And I believe we have someone from the law department here. So because this is an active negotiation around the restitution fund, we can't speak directly to the fund itself. We can talk very broadly about how we are thinking about building capacity of nonprofits and other partners in this space, but I would advise us against going into details about the restitution fund when we're actively negotiating.
Broadly is fine, if you're able to provide any recommendations that you have now or that you are able to share.
All right. Thank you, Madam CA, and thank you, Councilwoman. So, in terms of capacity building, and I spoke about this briefly at the beginning of my presentation when I talked about the structure and the processes. Regardless of where funds come from, we recognize that there has to be a structure and there have to be processes in order to be able to use them properly. It would be the same process that we apply whenever these funds are made available to the city. What we want to do is make sure that we have programs that are evidence-based and data-driven that tell us where there's efficacy. In other words, we want to get the best bang for our buck. Having said that, we're also open to looking at where there's innovation. Sometimes, you know, as people love to say, the absence of evidence doesn't mean there's evidence of absence. Sometimes you just have to be courageous about trying different things in order to get whatever you can out of it. There is no magic bullet when it comes to addressing the overdose pandemic, and therefore we're willing, frankly speaking, all options are on the table. But what we're doing at the moment is building, and I've spoken again, I'll repeat it, is spoken about the mayor's overdose cabinet. We do want to have a proper governance structure. We know that's important in order to have proper decision making. We are also operationalizing the overdose prevention team. Like I said earlier, this was signed by executive order by the governor. But these are the structures that will determine that we're looking in a data-driven way for all the evidence available for whatever we can use to address it. We will build the capacity not just within the health department, but across the city and all the agencies that come in contact with anyone that has a substance use disorder, so that when there are funds, we know exactly how to channel them. Does that answer your question, ma'am?
It does. Because I know it's supposed to be a broad answer. The reason why I asked it was because that was one of the FY2024 goals. It was regarding around capacity building, specifically for opioid restitution funding planning. It is something I can follow up with offline, but I did want to see if there was any information that you guys could release at this time, since it was a previous goal. Thank you.
Thank you.
Thank you, Mr. Chair, and I want to thank you, Commissioner, for that answer, because I think it says a lot about what we've learned and how I agree we should be going about this going forward, given the urgency and importance of this work. My question is about our relationship with outside partners like BHSB. Historically, we have worked very closely with BHSB and, in fact, chaired the board and otherwise. I'm curious how we work with BHSB now, and how those efforts are, how we work with them to address the opioid issues that we have across the city.
Thank you, Councilman. That's a great question, because we recognize BHSB as a very strong partner for us. Also, they are our local behavioral health authority. The Commissioner of Health does sit on the board and chairs the board of BHSB. For that reason, just recognizing it. But even more recently, which we're particularly excited about, is I've spoken a couple of times about this overdose prevention team, which is going to report up to the overdose cabinet. That overdose prevention team is broad across the city, across agencies, community partners. It's coordinated by the health department, but starting now, we are co-chairing that team with BHSB. That way we know that we have an authority, somebody with experience and expertise to help guide the direction of that team, because that team does represent the people who are boots on the ground. That is probably one of the most exciting and significant things that we're doing with them. But there's so many areas in which we stay informed in the work that BHSB does. They oversee providers. So we recognize that by working with them and co-chairing this team, we're going to get the best of the expertise that we need to go in the right direction. Does that answer your question, sir?
Partially, yes. I'm curious, do we provide funding, and how much?
We do provide funding, so a huge amount. But if you look at FY2025, I want to say it's in the neighborhood of $800,000 that we provide to BHSB.
To that effect, one of the things we talked about, Madam CA talked about it, I think earlier on in this process, was opioid stat. Have we been thinking about what that might look like, how partners like BHSB might participate, and how feedback from other partners like the fire department, the police department, and our first responders might be a part of what may help them and help us on the policy side in the health department? Have we done any thought about that?
We actually have. And so with the new health stats that we're putting into place, we're actually separate. I mean, the health department has multiple metrics that we want to track, but recognizing the importance and the significance of the overdose epidemic that we're dealing with, we've separated out of that a specific opioid stat, even though it's being coordinated by the health department. So sorry. We do have the contribution from the fire department. We will have OPI involved in it. So yes, this will take out that metric from the rest of the health department metrics. And we want it in such a way that we can follow that data closely and in almost real time, so that if we have to course correct, we don't go down the wrong path for too long before we recognize that it's not effective.
Last question, when will we start meeting, and how often do we expect opioid stat to meet?
At the moment, the conversations have been around monthly meetings. So we expect within the next month, we will have the first opioid stat, and monthly after that. I don't know if it will be more frequent than that, but I doubt it. I do believe that monthly is enough to have real-time data and course correct in good enough time.
Got it. Thank you. Thank you, Mr. Chair.
Thank you.
Thank you, Mr. Chair. And again, thank you, Madam Commissioner. I want to lift up and thank Deputy Commissioner Tan for all of her great work in the older adult space. And really want to also thank City Administrator, my colleague over here, Vice President Middleton, Director Harmon, who I see over there, in creating a new cabinet level office to support older adults and older adult advocacy. Really proud of that effort, really proud of how Baltimore is moving aggressively to support a community that we know is the fastest growing in the United States, has complex needs, but is also such an asset for our city, as a city with so many multi-generational homes where older adults are an enormous value within our communities. As I'm reading through the budget, I wanted to understand the interplay between the health department and the new office. It seems most of the funds still sit within the health department, and so want to understand sort of how we're thinking about how those two separate entities engage and interact.
Real quick, before you answer that, is Andoria coming up to join us? Andoria is here, very good. Thank you, please continue, Commissioner.
So thank you for the question. And actually, since Ms. Andores, I'll also ask herself and Deputy Commissioner Tang to pitch in. I do know that the Health Department and this new office are working very closely together. We've had multiple events in the past several months in which we have coordinated them together. In terms of where the money sits, I understand what you're saying, because a lot of the services still do lie with aging, and we recognize that advocacy in itself and the work that Ms. Ondore is doing requires funding. But I'm going to allow Deputy Commissioner Tang to take it from here and explain how she's working together and what other plans will be going forward.
Thank you, Commissioner. Thank you, Councilman, for the question as well as your partnership in the development of this new office. Also wanted to acknowledge Vice President Middleton for her advocacy and work around this, and the City Administrator, who is also here. And with regard to the budget, I think during our discussion around this office has its independent owned budget. I believe the hearing for that office was a couple weeks ago. It is 100% general funded in a separate general fund in a separate office, as it's an independent office. The funding in the health department is primarily grant, federally, state, and Medicaid funding. And I think during our discussion, we were going to keep the grant-funded programs within the health department as the area agency on aging, where all the direct services work would lie, in addition to the independent office would have the general funded support and the positions supported by general funds. I'm happy to take specific questions, but just wanted to kind of highlight the funding under our budget is primarily funded through grants of federal, state, and Medicaid reimbursements.
Deputy, I appreciate that. Could you speak, and again, I want to thank you for your long and underappreciated leadership in this space, both here in Baltimore and across the state. The 723 advocacy for older adults, how much is that grant funded? Because again, that to me does seem like a service where we would consider transitioning it into the office that supports advocacy for older adults.
Of course, I think the 7.2, and I can pull up the agency report, but that's primarily grant and state funded. The majority of it is for the long-term care ombudsman, which oversees abuse and neglect in long-term care. That is state regulated, funded for advocacy services for older adults. Another state-funded program is for the State Health Information Program, which is Medicare enrollment, which is also state-funded. The only general funded position is the $138,000, which is for the full FTE for the long-term care ombudsman, which we needed because we only have 3 long-term care ombudsmen to navigate the neglect and abuse investigations in the long-term care facilities. There are about 30 nursing homes as well as 500 assisted living facilities. So that we had to augment with some local funding to help support that program. But the majority of the funding in advocacy services is state funded under the Older Americans Act. And we might have to redetermine the name of that service area because advocacy is direct advocacy in terms of connecting services to older adults, not in the advocacy in which Director Harmon is in charge of, which is high-level systems advocacy and public policy.
Understood, and again, appreciated, and have really appreciated the work that Director Harmon has been doing, just out in community, connecting, and we've had a number of really great conversations. And I don't want to speak for my partner over here, who is really the leader on the council in this space, but I will just say for me, I think it is really important that that office be able to be visible enough that our older adult community knows it's there and knows that it is a connector for them, whether that means in partnership with some of the schools of social work, whether that means in partnership with, of course, your office within the health department. I just want that office to succeed and to really demonstrate commitment to our elders and to have the funding that it needs to be successful. And again, just grateful for you all working with us on that legislation. You all working with us on that legislation, and look forward to continuing that conversation about how the two work together.
Thank you, Councilman, for your question and for your comment. I also just wanted to highlight the model that you're developing in Baltimore City is a model that they're looking across cities. We're involved in the mayors of conferences. We're looking at how advocacy and direct services are split, and that's necessary in that case, having that piece of coordination and really oversight around direct services. And so really wanted to kind of just highlight that, and it is looked at as a model on a national level now.
Thank you.
Councilwoman Porter.
Thank you, ma'am. Commissioner, I wanted to ask about school-based health centers. That's an area where I believe you have the most expertise, and I'm really super excited about that, given your leadership in that area. But also from the state level, we've been in discussions about how we can expand school-based health centers throughout the city using the Kerwin dollars. And so can you share kind of what the plan is, what the approach is on how we're going to move forward with expansions of school-based health centers?
Thank you, Councilwoman, and you're right. It's an area that's very near and dear to my heart because there are many public health initiatives we often claim help to level the playing field, and I say it all the time. Most of that is a myth. There are very few things in life that really level the playing field, but school health actually does. And school-based health centers have the potential to do that. Having said that, the city health department is not always best positioned to operate a school-based health center. This is one of those areas where collaboration and partnership is the name of the game. We really need to work harder with our clinical service providers across the city, specifically our FQHCs. One of our FQHCs operates, I want to say maybe 4 or 5 school-based health centers, for which we're very grateful. So our work as a health department really is a lot more advocacy to some of these organizations so that they can buy into the school-based health center vision. We recognize it's not a money maker, and that's why it's so hard to sell. When you talk about not-for-profit health, school-based care is it. It's just not. And so we as a city, as much effort as we can make, and I will appeal to everyone here on the council as you speak to your constituents, as you raise the interest and raise awareness and just the importance of how this really does level the playing field for our communities. That advocacy can go into some of the FQHCs and the clinical service providers within the communities. As a health department, we're happy to help with convening, we're happy to help with policy, we're happy to help connect people with grants and opportunities to have some of this work supported. We just don't have the capacity to provide it. And frankly, it would be wrong of us to do something if we're not positioned to do it properly. So that really is the best that we should be doing. And I look forward to more. I know we have a hearing coming up on that, and I look forward to that.
So one of the things, I'm going to push back a little bit, and I'm going to kind of expand us out. One of the things that I really want us to really focus on is the co-collaboration with any agency. So if it is health related, you know, I don't want us to kind of take the position of being secondary. I understand that there has to be a designated responsible agency, but I really want us to take that position hand in hand, and particularly with the school-based health centers, when we're talking about the advocacy of facility requirements, clinical services, immunizations, which comes out of the health department, making sure that we integrate those services within the school-based health clinics. That can provide us with the kind of co-collaboration lever that I'm talking about. For example, and I know I have time, for example, immunizations. There were a number of children in Baltimore City Public Schools that were not immunized before the first day of school. That is something that the health department can really play a role in making sure that we not only collaborate with the FQHCs in the area, if they have an FQHC in the area, or with the school. And so I understand that, you're not necessarily the primary agency because it's coming out of Baltimore City Public Schools, but speak to me, or can you just let me know what that plan of the health department will be given the current services and operations of the health department to co-collaborate this plan?
So Councilwoman, are you speaking specifically about vaccination services?
No, so I'm not speaking specifically about vaccination services. What I'm speaking about is the broader operations of the Baltimore City Health Department and the co-collaboration of that plan with Baltimore City Public Schools.
Okay, so people often use the terms interchangeably, school health suites and school-based health centers. Not everyone recognizes that they're very different. School health suites are what we all know as the school nurse. I bumped my knee, I bruised my elbow, that's the school nurse. School-based health centers are like little clinics that we stick in a school. And so those are few and far between. Where we make a lot of traction, frankly, is those school health suites that are present in almost every school. And we do work closely with city schools. Obviously, the health suites are located in the schools. So we continue to work with city schools. We have upcoming conversations, actually, about how we continue to do that work. And I will tell you, many people don't realize this, but Baltimore City does have one of the highest vaccination rates across the country. How we do that is a whole coordinated effort, but we do quite well, and a lot of that is because of our partnership with city schools. So that relationship is definitely not falling apart. We rely on city schools to get a lot of this work done.
Yes, ma'am. And Madam Chair, may I follow up for 2, please? Just 1.
Comprehensive and brief.
Okay, yes. For the immunization, you are correct. For Baltimore City, we have one of the highest immunization rates across the nation. However, by district, based on the health disparity, there's a vast difference of South Baltimore versus Govan. So there's a very different disparity there that I want us to kind of keep in the forefront. Number 2, with regard to the school health nurses and that partnership with Baltimore City Public Schools, while we have a strong partnership there, we are still existing in a space where some schools do not see their school health nurse on a very consistent basis because of the workforce shortages of school health nurses. And so what I'm saying is that, with the school health suites and the school-based health centers, there needs to be some sort of integration there, because if there's a health suite there and a school health nurse, there needs to be an integration there so we can maximize the touches to the community. Thank you, Madam Chair.
Yes, ma'am. Thank you.
Thank you, Councilwoman Ramos.
Thank you, Madam Chair. I do want to give a shout out to Animal Control. They're doing a lot. And Director Colburn is always very responsive and explains things very detailed, and also talks with constituents about, you know, their pets in a way that is supportive and helpful and informational. What is the capacity of Barks?
Councilwoman, when you say capacity, are you
How many
referring-
animals can Barks hold at one point in time, like maximum at point in time?
Okay, I'm not sure we have that exact number, but I'm gonna check. Deputy Commissioner Howard, do we have a number? Because I know we were quite overwhelmed by what happened 2 weeks ago.
This is why I'm asking.
Yes.
We do have we're able to, Sharon Colburn is here.
Thank you.
Hi, Director.
Hi, Councilman Rivas. So for dogs specifically, it's about 100. However, they do
I'm
have...
sorry, can you
I'm
repeat
sorry.
your name
My name
again?
is Sharon Colburn. I'm Director of Animal Services. Thank you. So for dogs specifically, which we usually have a capacity issue, that in-shelter capacity is approximately 100 dogs. However, Barks does have many fosters and many volunteers, so there could be 200 or 300 other animals in their custody, but in homes.
Right, I'm thinking, thank you for that. I'm
Yes.
thinking specifically for the building, right at the moment.
For the building, just 100 dogs.
Mhm.
I don't know the exact number of cats. I would say 100 to 120 or 30, but dogs is usually where we have the highest intake and the capacity issues.
For sure, they're a lot bigger than cats.
Yes.
Yes, I understand. And when was the last time that Barks, the building, was expanded?
So in 2020, I believe, we made the move from the shelter by the M&T Bank Stadium to the South Baltimore Cherry Hill. The capacity wasn't necessarily expanded at great length. However, the quality of the housing was improved. They have much bigger cages, much bigger space, better HVAC system to reduce disease and illness, 7 acres of property for exercising, walking. So it kind of increased the quality of the space, not necessarily the capacity. We really don't want to exceed 100 dogs in capacity, to be honest with you, because then you'd increase your staffing. So that's why Barks relies heavily on foster and volunteer relationships to get dogs into homes. Dogs that are in the shelter are very stressed and at high risk of illness and injury, so it's much better to get them out of the shelter into a rescue, a home, a foster, or adopted.
Thanks for that, because where I was going was maybe we need to expand the shelter, and you're saying, no, that's not really the answer. It's more about working on personnel capacity, obviously, and I know you have a lot of dedicated super volunteers, which I appreciate. As was said earlier, you know, this is not just the 83 dogs crisis, but it's a crisis writ large. I think mostly because of the eviction crisis, frankly. And so what would be your suggestion for addressing this crisis? It could be expansion plus staff, it could be, what is your suggestion?
I see the biggest issue is our community doesn't have the resources to provide basic preventative care. And in going beyond that, when something does happen, their dog is sick or injured, they don't have the funds or resources to provide care for that animal, so ultimately they're surrendering it to the shelter. So Barks really wants to focus not on taking in more animals, but providing better resources and more resources to the community to keep pets in homes.
So we had heard about sort of the economic issue with maybe people are breeding dogs to try to make more money. There's also what I just said, the eviction crisis, and what you're saying is because people are suffering economically, they're not able to afford care for their pet and therefore end up surrendering to Barks because it's just overwhelming for them. Is that correct?
That's 100%.
And so your suggestion is really more around what are some other resources that we can provide for families to keep their pets?
Correct. Currently, Barks does like a case-by-case right now where they can help an owner with medical care, low-cost medical care, low-cost surgeries in order to keep that pet with them. However, they just don't have an enormous amount of funding to help the entire community within Baltimore City. So that's really their goal, is to reduce the intake, keep pets in homes, and provide resources for them for training, medical care, food, anything that is required to keep the pet in that home with that family.
Thank you very much for that
Yeah,
detail. I
no
really
problem.
appreciate it. Thanks for
Okay.
all you do.
Thank you.
Thank you, Madam Chair.
So, Sharon, I don't know if you want to stick around or you can grab a seat. So what, I missed the first part of this. What more can we do for Barks here? What does Barks need? Because I've had a number of folks reach out expressing concern that they're under-resourced.
So I'm happy to have the team to respond, but I do want to acknowledge what has been done for Barks to date. So last year, we actually received a funding request from Barks for additional funding. We provided them an additional 9% last year, so an additional $120,000. This year, we did a 5% increase to Barks as a part of this year's budget. So I think Barks is at what, 1.5 million, if I'm not mistaken, Bob? So over the past 2 years, we provided a pretty significant, a little less than 20% funding increase to Barks.
Greatly appreciated the enhancement that was provided last year of 9%. Do we know what their request was last year?
I will pull it up.
Thanks. And did they make an additional enhancement request for this year in advance of hearings?
Not that I'm aware of.
Okay.
I think as a part of, and the health department team can speak to this, I believe, because I believe the health department added a CSL, like as a part of their current service level in their submission, they might have included additional funding for Barks. But the health department can speak to that.
We did. We included about $84,000 for Barks in FY25.
As an
extra $84,000.
Request to BBMR.
Well, not just a request. Our budget actually reflects.
Well, correct, but
Yes.
but the preceding the budget is the request that the agency makes. How much was the request that the agency made?
That I'm not sure about, but I guess we will have to pull it up and check. I don't recall if there was a request. There was none. Okay, there was no request this year.
And did
Councilman, I think they were just able to shift a little bit more over towards Barks within their target, within their budget.
Say that again?
I think they were just able to shift some resources
Within health?
within health.
Within
department
health,
budget.
without a request.
Okay. Do we know what, did Barks ask the health department for an increase in appropriation?
So I think that's what we're saying, that we didn't. Did we get a request from them?
I believe I saw a letter, but it was after enhancement requests had already been submitted, and it wasn't specific to enhancement. It was a general letter regarding their financial outlook, asking for, I don't remember the amount, but it was a larger, much larger amount.
Okay.
Yep, so I'm still pulling last year's enhancement request, but in January, I received a letter from Barks just talking about some fiscal challenges. There was not a dollar amount that was requested.
Okay.
Mr. Chair, I had asked early on if they needed to expand their space to provide more services, and the answer was that wasn't necessarily the solution to the issue, because they would also have to extend staffing, but that providing more of the services for people who cannot afford health care for their pet could be something that could resolve the issue so that people could keep the pet in their home rather than surrender it. That's what I was hearing.
Correct, yes, absolutely.
So that makes all the sense in the world. I mean, we just built them a, what, 18 or $20 million new facility in Cherry Hill?
Correct, 16 million.
16 million. Okay, so I have a committee request. So Bob, can I get a meeting with you, and who would be the appropriate person for the health department who kind of oversees Barks? Is that Mary Beth? Okay, so can I get a meeting with Bob and Sharon and Mary Beth and Jen from Barks and her CFO or whoever she wants to bring? Jen's fantastic, she's wonderful with animals. She knows how to run an animal shelter, clearly. What Jen doesn't know how to do at all is like deal with the appropriations process for the city and articulate exact needs. That's not like a shortcoming of Jen. Like, Jen runs an animal shelter. It's like not intended to insult Jen. I want to get the people together who understand this, who can help her for future years articulate what it is that she needs and how she can work within the city's budget cycle to effectively advocate for additional resources to meet the growing needs. So, Bob, if you could have someone from your office coordinate that meeting, and I'll defer to Mary Beth and Sharon if there, or the CAO, if there's anyone else who should be in that meeting, so we can kind of do a baseline reset with Jen and figure out how we, moving forward, how we can do more.
Sure. So I want to go back and clarify a statement. So we did receive an actual request from Jen. It was, or from Barks. It was in January for $1.7 million. And so I have to go back and look at.
Sorry, Faith, additional or one, okay.
Additional $1.7 million. So I have to go back and compare the request that came in last year, because the way that we've been thinking about that request is that we can't meet $1.7 million in one fiscal year, but over time we can work to increase their allocation, which is why we did the 9% last year and the 5 or whatever the percent is this year. But happy to also provide this to the committee.
Excellent. And closing point on this, you clearly just identified the issue that I was raising about Jen, and that the request came in January. That request should have been in no later than September or October of 23 in order to potentially get movement or more movement on it. Not to say that it would have been funded if it came in September, but there was a better chance of additional funding. So, okay.
Mr. Chair?
Someone said, Mr. Chair.
Yes, right here. Yes, sir. Vice President Middleton and I were just talking. Can we actually be included on that meeting as well?
Let me get back to that in 1 second.
Mr. Chair, I don't have to be included on the meeting, but I just want, you know, you're talking about the funding and services. We also need to know, you know, are you connected with other programs like hospitals or for, you know, pets are now used to help in trauma situations with people. Is there a connect with Barks on, you know, it's another avenue of getting pets to people that, you know, need, you know, pets or therapy and help with healing. And we know that hospitals have programs and they get dogs to, you know, work with the child or adult that needs healing. Is there some kind of program like that or partnership to give pets that way?
So what I believe you're asking is, tell me if I'm not answering this correctly, but, so Barks has many programs. One of the programs that they have is they will bring school-age children in, and depending upon their age, they may work with the cats, they may work with the dogs, and it's very therapeutic to them, or other vulnerable groups they may bring in. And depending upon what their ability is, they will match them with a dog or a cat. So they do have many programs that benefit the community in that sense. They partner with many vet hospitals in the city. These vet hospitals actually discount services to Barks when they have to use these veterinary hospitals. So there's many partners and organizations that work with Barks in our team. And it's just a wide range of programs, and serving the community with lower cost resources is definitely a primary goal for them.
Thank you. You answered the question.
Yes, ma'am.
Okay, so back to the meeting request. So Bob, someone from your team can coordinate, and we'll have health / Sharon and Jen and whoever else you all deem appropriate. Happy to have other council members involved or participate. I plan on taking the lead on this. This is a priority for me, and I want to get this on the right track before December. And I hope that the administration will work with me on this. It's very important to me. It's very important to a lot of people. So, thank you. All right. Back to the top. Council Vice President Middleton, Vice Chair McCray, Conway. Happy Zooming.
Me?
You are Councilman Conway.
That's my name. Thank you, Mr. Chair. I'm staying along the theme, and I'll eventually get off this theme. I just want to make sure I get all these questions out. I have a question about substance abuse. I noticed within the performance measures that the number of consumers admitted to the Crisis Stabilization Center has gone up significantly. We've seen a spike in the number of folks, the actual numbers going to the Stabilization Center. I had an opportunity to go out there. I really appreciate the work that we're doing out there. I'm curious, do we have enough resources there? Does that spike represent anything to us that might suggest maybe a red flag or something that we should be paying attention to? In my mind, I realize with opioid deaths, we can give folks naloxone, but if they are still addicted, we're always going to be sweeping sand on a beach of sorts. We need to get people out of addiction and into recovery. This is one of those opportunities. So I'm curious what that number tells us and how we're reacting to it.
So thank you, Councilman. And you did point out correctly, treatment is part of the prevention. And this is part of the work that BHSB does do overseas, I would say, on behalf of the city. Our partners from BHSB are here in terms of probably providing a little more detail about what happens. I'm so grateful that you went to Turk House, I believe.
Yes.
Yeah, okay. Yes, I'm happy that you went there. It is good work that's being done. And the treatment aspect, so what the health department does oversee is a program we call Levels of Care. And what Levels of Care does is kind of what you're describing, connecting people who have come in, survived an overdose, were in the ER. Okay, you survived it, you're alive. How do we make sure this doesn't happen again? The extent to which they engage in that connection is what determines what we call the Levels of Care program. And we have it up to levels 1, 2, and 3. And we have a few institutions, Hopkins, Bayview, Hopkins, the hospital, a couple others, I believe UMMC, at the level 1, where there is a strong connection. That's how people end up in Turk House. But in terms of the capacity, what ideally we would want, and we've actually had a conversation with the fire department about this, is how we develop a dashboard. One of the cities, and because I might say the wrong city, I'm not going to say which one, but one of the cities across the country does have a dashboard where it is maintained in real time, which means if I have a patient come in, I can go to the dashboard and I can see 16 hospitals across the center, 2 beds here, 1 bed there, 3 beds here. We would love to have that. My last conversation with Chief Matz was around that. What can we do to light up in real time where people can be connected? So that is something that we aspire to do. That's something we recognize, and that's how people end up at places like Turk House, knowing that, first of all, those facilities are available, but then actually knowing in real time where's the first place to go to. I don't know that this really answers your question, but it does tell you that it's something that we're having conversations about.
It doesn't, but I'm really happy to hear it. The sort of crux of the question I'd like to get to, though, on top of that, is capacity. Do we have enough beds? Do we have enough staff? Do we have enough resources to meet the need and demand for folks that are in recovery?
Okay. Deputy Commissioner Martin, do you want to speak, or would you like me to invite BHSB?
Yeah, thank you, Dr. Amanuga, and thank you, Councilman Conway. I think we should hear from Behavioral Health Systems Baltimore as they oversee the Crisis Stabilization Center. So I'd like to invite them up.
Good morning. Thank you for the question. Adrienne Bridenstine, I'm the Vice President of Policy and Communications at Behavioral Health System Baltimore. So to your question specific about the Stabilization Center, yes, we saw capacity increase. That is a result of the COVID protocols being lifted. When we had those COVID protocols in place, we could only serve, the bed capacity was 17. It went up to 35 when we were able to do that, and we saw our capacity increase and the number of people coming through our doors increase. So that's the reason for that increase year over year there.
So this is more a reflection of the real need or the real demand for this service as we see it increase. Now, do we have enough resources in order to meet the need, or?
So the Crisis Stabilization Center, as you all know, is sobering services. We look at it as an access point to the broader system of care. What that means is people who come in, they safely sober, they stay for 24 hours or so, and then get connected to ongoing care in that broader system of care, which for most people, it's outpatient mental health or substance use treatment. So that's your medication-assisted treatment types of programs, your therapeutic IOP programs. We have that full continuum here in Baltimore City. So the people who are getting connected to services through the Crisis Stabilization Center are getting connected to those services, and we are seeing that they are staying connected to those services, partially because of the 30 days of case management people get when they are discharged from the Crisis Stabilization Center. I don't know if that answers your question or not.
Not exactly.
You know, we are seeing utilization of public behavioral health services system. We did see a slight, I've got those numbers in front of me because I thought I might be asked. So give me a second. You know, majority of people do get treatment in the outpatient portion of our system of care. So we have seen a slight, actually, outpatient services have been steady. Around 14,000 people annually get services through our IOP services, through medication-assisted treatment. So that's been steady in this system. There's certainly areas for growth, for sure. If we need to have that, that's a conversation we have with the health department and with the state health department.
Okay. Still didn't quite get the answer I'm looking for. That's okay, and it's maybe we can request it as a follow-up. I'm looking to understand the utilization of the stabilization center, specifically folks who are admitted, the number of beds, how often we utilize those beds. Do we have enough beds? Do we have enough staff to meet the needs for folks who are in for treatment? That's what I'm trying to wrap my head around. Maybe I'm asking it the wrong way, or maybe we don't have exactly that data, but that would tell me ultimately, you know, this is one of those first steps on the road to recovery, and do we have the capacity to meet the demand for that first step is what I'm trying to figure out. Does the system work on its first step?
So it sounds like what you're asking is, does everyone today who needs treatment and willing to go into treatment have a place to go?
Precisely.
And I don't have the numbers, but I'm sure that most folks here on our department will tell you not necessarily. Sometimes people have a wait time, which is probably the worst thing ever, because we have a very narrow window when a person is revived from an overdose and says, you know what, I don't want to do this again. Give them a couple more days and they change their mind. So the fact that we have a wait time in some of these facilities and there aren't enough beds and there's not enough staff is a real problem.
Thank you for clarifying that. And so to that end, I would love that capacity for the stabilization center, but even more, the demand and how much that exceeds the capacity, why folks don't necessarily have a place to say when they have that moment of clarity and say, look, I want to get clean and take that first step. How many more people reach out to us and we are unable to help them is what I'd like to know.
Yeah.
Well, I think the team and you all can weigh in on this. I think we should think about this as an ecosystem. It's not just the stabilization center. We have a number of partners and providers and drug treatment facilities. Some are outpatient, some are residential. So the health department would be making referrals to the appropriate partner whenever there's someone that needs assistance. So the team can speak in more detail about that.
I think that's an excellent point. We have other partners outside of city partners that help people dealing with addiction. If we have an assessment of that additional capacity as well, I think, once again, we have to bring all the people to the table. We're dealing with an issue that is bigger than Baltimore City, but lands disproportionately upon us. And so as policy leads on this, we want to think about what we can do to get it right. So, yeah. So as a formal request, you guys understand what I'm asking for, capacity for our controlled stabilization center, the demand that exceeds the need, or exceeds the access, and if we have some sense of other providers, other folks that help with stabilization center type services that we often rely on, what is their capacity, is what I'd like to know.
So just related to that, so one of the, as Madam CA pointed out, treatment isn't just inpatient, because that's what Turk House is. Treatment is also outpatient.
Right.
And that's one of the greatest areas of opportunity, is the outpatient treatment. On the policy side, and many people may know this already, just the removal of the X waiver made a big difference. So, back in the day, you had to be trained, had to be properly certified in order to give substitute treatment or medication-assisted treatment. That waiver was removed a couple of years ago, which made treatment of substance use disorder mainstream primary care. That is one of the greatest changes that has happened in our time that makes this difference. But then, of course, growing the capacity in these primary care environments to do that is another thing. Like I said before, the health department is not a primary provider of primary care, but we convene people. The Local Health Improvement Coalition is something that's chaired by us. So the primary care space is probably going to be one of our greatest opportunities to utilize right now, so that this becomes mainstream and is also much less stigmatizing. If you come in for your flu shot and your Suboxone prescription, it's very different from if you have to line up outside a drug treatment facility.
Right.
And if I could add, just since you brought up a policy change, another great policy change that'll help us with crisis stabilization centers is as of July 1, it'll be reimbursable through Medicaid. For years, it's been grant funded. That will allow us to expand capacity, but it'll also get to your question on need, because we'll be able to look at better data, through claims data, to see who's coming through our doors and if we actually are meeting the demand.
Thank you. Thank you, Mr. Chair.
Thank you. Ramos?
I'm fine, thanks.
Thank you, Mr. Chair. I had another quick question about the health corps. Are you all still utilizing those community health workers, or have any plans for those community health workers?
Councilwoman, which ones in particular are you referring to?
So there were about 300 community health workers that came in under Dr. DeRaza, labeled as the health corps. Okay, thank you.
Yes, Deputy Commissioner Martin.
Thank you, Dr. Amuga. Thank you, Councilwoman Porter. Yes, we, during the pandemic, did bring on and hire a large number of staff, and those staff were used across multiple areas of our COVID response, including our contact tracing, our vaccination, as well as some of our food and older adult programming during the response. Those staff are being funded through our ARPA dollars in the health department. And so those dollars, of course, are coming to an end in the next few months. So many of the staff who started out with us have transitioned on into other positions. Some have transitioned into positions in the health department. Some have transitioned into positions in other parts of the city and other partners of the city. And then, you know, we've had folks who decided to retire, folks who decided to go back to school, folks who have moved to other parts of the country. So it's been attrition, as you see in any part of any organization. We do still have some staff who are part of our programs now and who are currently still part of our efforts that are ongoing, but many of them will be rolling off in the next several weeks, and then with others rolling off at the end of the calendar year.
Oh, thank you. Thank you so much for that. I wonder if there's an advocacy opportunity. One of the main issues that we're seeing with community health workers across the state of Maryland is the reimbursement for their services. I'm wondering if that can be a part of the legislative agenda for the city health department at the state level this upcoming year.
It actually is a priority for us right now because we've spoken about, our policy director is actually part of a coalition we didn't even know existed, but she's just joined, that is talking about community health workers, how they're certified, how they're reimbursed. We've had conversations at the leadership level at the health department so that everyone who has community health workers within their division begin to prepare them, because as we know in healthcare, if you're going to pay for a service, you're going to ask for a certain level of certification. Heaven forbid that when the time comes and people can be reimbursed, it turns out that we don't have the certification, and that would be an indictment on us. So we are trying to look at who we have, what needs to be done for them to be certified, so that once that reimbursement structure is there, we can benefit immediately.
And that's great to hear, and I'm wondering how we can utilize the hospital partnerships, because they also have community-based health workers within kind of their operations, and so that will provide that bridge from the city health department within our hospital system so we can continue the work. Thank you.
Thank you.
Colleagues, any other questions for the health department? Commissioner, thank you to you and your team. Greatly appreciate your work. We are now in recess until 1 p.m. for
Thank you, sir. Thank you, everyone.
Broadband and Digital Equity and Chief Data Officer. Thank you.